My name is Barry Coller, and I have the privilege of serving as the Rockefeller's Vice President for Medical Affairs and Physician-in-Chief of the university's hospital. It is my pleasure to welcome you to the Women in Science Fall Breakfast Program. The Women in Science initiative was launched in 1997 to make it possible for New York women in business and philanthropy to learn more about science and to serve as a source of support for the women scientists at Rockefeller. If this is your first visit to the campus, we hope that you will become involved with the Women in Science initiative. And if you would like to be added to our mailing list for future events, you may sign up at our registration table or on your way out or log on to our website. You can find the web address on the last page of the program. You will also find in your program an announcement for the next Women in Science program, the presentation of the 10th annual Pearl Meister Greengard Prize on Thursday, December 5th. The award recognizes outstanding women in biomedical science. This award was created by Dr. Paul Greengard, a Rockefeller professor, and his wife, Ursula von Reitingsward. In 2000, Paul donated his entire monetary share of the Nobel Prize to establish this award. A small group of generous benefactors joined him. The recipient this year is Dr. Huda Zagbi, a neurobiologist from Baylor College of Medicine who has made pioneering discoveries in the study of pediatric neurology, most particularly the genetics of autism. Today's program is about heart disease. As a prelude, I want to share with you how Rockefeller scientists have contributed to our understanding of cardiovascular illness. By now, nearly everyone knows that there is a relationship between cholesterol and heart disease. What you may not know is that link between them started with studies conducted in the Rockefeller Hospital in the 1950s and 60s by Dr. Pete Ahrens. By putting patients on different diets and analyzing their blood lipids, he showed that consuming more unsaturated fat can actually lower your blood cholesterol. A current Rockefeller scientist, Dr. Jan Breslow, who's in the audience this morning, has made critical contributions to heart disease genetics. He pioneered the study of the genes that produce apolipoproteins, the molecules that transport cholesterol in the blood. In the 1990s, Dr. Breslow's laboratories used its knowledge of genetics to create a mouse that develops atherosclerosis, the accumulation of fatty deposits in the wall of the blood vessels that's the prelude to a heart attack. This mouse model has been used in laboratories around the world to investigate heart disease and to develop new therapies. More recently, Rockefeller scientist Dr. Rod McKinnon shared a Nobel Prize for solving the molecular structure of a potassium ion channel. And this is a member of a family of proteins that play essential roles in regulating heart rhythms. Many of the drugs used to treat hypertension act on ion channels. With these just few examples, I hope that I have convinced you that the pioneering research at Rockefeller has made important contributions to our understanding of heart disease and how best to treat it. And now on to today's program, Affairs of the Heart, Gender Differences in Heart Disease and Stroke. I would like to introduce our speaker, Dr. Holly Andersen. Holly serves as the Director of Education and Outreach for the Ronald O. Perelman Heart Institute at New York Presbyterian Hospital. I am delighted to add that Holly is also a trustee of Rockefeller University, a member of the Women in Science Committee, and a member of the Rockefeller University Hospital Committee that oversees and guides the Rockefeller University Hospital. Cardiovascular disease is the #1 killer of women in this country, a statistic that surprises many people. Fortunately, biomedical researchers are now focusing on how to better prevent and treat coronary artery disease and stroke in women. In particular, scientists have identified gender differences in cardiac symptoms and in responses to prevention and treatment measures. Understanding these differences allows us to improve therapy. Holly is at the forefront of redefining the role of the physician, from someone who treats sick patients to someone who keeps well people healthy. And she has become a leading advocate for improving women's heart health. In addition to being named a perennial Best Doctor, Holly holds a number of leadership positions, including membership on the boards of the Michael J. Fox Foundation for Parkinson's Research and the International Women's Health Coalition. She's also a member of the Leadership Council of the American Heart Association's Go Red campaign. In the interest of time, please refer to your program for more information about Holly's many awards and recognition. And now, I am pleased to welcome Holly Andersen to the podium.
I am very excited when I'm at Rockefeller all the time because it's such a phenomenal place to be, science for the benefit of humanity. And I'm so honored to be a trustee of this great institution. I'm honored to be here this morning to share with you my world and some of what I do. Heart disease is the #1 cause of death for both men and women in this country. More men and women die of heart disease every year than all cancers combined. And more women have died from heart disease every year in this country since 1984. And once a woman gets diagnosed with heart disease, she will do worse and will be more likely to die from it than a man. And as of 3 years ago, heart disease became the #1 cause of death for women worldwide, more than infectious disease, more than childbirth. Now, most of what we know about heart disease has come from studies on men designed by men. And this has greatly benefited men, but women have not fared as well. While death rates due to heart disease has fallen for decades in this country for men, you can see that that has not been the case for women. And here is the rather pivotal year of 1984. And the most recent population data show that since the year 2000, heart disease, youngest men, age 29 to 45, this decrease in death rates is now plateaued and may be increasing. And death rates due to heart disease in our youngest women, age 29 to 45, is now increasing at a concerning rate. Now, it's not just our discrepancy in knowledge that contributes to women dying more frequently of this disease. It's that women are treated less aggressively at every point along the way. A woman having a heart attack in this country today will wait longer before presenting to the emergency room. She will be less likely to have the classic symptom of chest pain. In fact, 40% of women having heart attacks today don't have any chest pain. She will be less likely to have a diagnostic electrocardiogram, and not surprisingly, she will be less likely to be diagnosed correctly. But even if she is diagnosed correctly, she will be less likely to receive all the life-saving therapies we have to treat heart attacks today. And even if the decision is made to give her these therapies, they will be given, on average, at a 13-minute time delay compared to a man. And for those of us who treat heart attacks, we have a saying that time is muscle. And even if you control for all of these variables, a woman will still be more likely to die of her heart attack. And it's the youngest women who have the greatest death discrepancy rates compared to the youngest men. And we don't know why. We are working on this through research and through enrolling more women in clinical trials. Women are far less likely to enroll in clinical trials of heart disease. When a female is the principal investigator, she will enroll more women, but they remain a significant minority. This is Bernadine Healy. She was a female cardiologist, director of the NIH between 1991 and 1993. And she was one of the first people to recognize, pay attention to, and be in a position to do something about the fact that now more women were dying of this long considered disease, this disease long considered to be a male disease. And she started the Women's Health Initiative, which is the first national study of women's health and preventive health, and it included cardiovascular disease. Now, it is important to do more research, and we must enroll more women in trials and do this research. But we could be saving lives today by increasing women's awareness, just increasing awareness about women and heart disease. Women in this country know they're at risk for breast cancer, but they're not as well familiar with the risk of heart disease. And 12 times as many women die of heart disease in this country as breast cancer, and more women die of heart disease at every age than breast cancer. And currently the NIH invests over 5 times as much in research in breast cancer as they do in heart disease in women. And women not knowing, not only are not aware of the risk, they're less likely to act. There was a 2010 American Heart Association survey that found that women in this country who thought they were having a heart attack would call 911. 55% of women who thought they were having a heart attack would call 911. That means that 45% of women who thought they were having a heart attack would not call 911. Now, they didn't tell us why, but I'm too busy, can't really have a heart attack right now, have to go pick up my daughter from school. And there was one study that showed how when EMS was called by people who were suspected of having a heart attack, they got to the callers' homes at the same amount of time, but women were 55% more likely to suffer a delay getting back to the hospital. So at every point along the way here, we could be improving things for the outcomes of women. Now, when I talk about heart disease today, and most people when they talk about heart disease, we're talking about coronary artery disease, or blockages in the arteries that supply your heart with blood. And this is the heart, and these are 3 main arteries. This is the main one that goes down the front part of the heart, the left anterior descending, also called the widowmaker. The one that goes down the side and around the back, and then another one that goes down this side. This is the aorta, the main vessel that leaves the top part of the heart. So I want you to concentrate right here, because I'm going to take this and I'm going to give you a magnified picture of that here. And this is a rather healthy artery that goes down the top part of the heart. And this is a rather diseased artery that goes down the top part of the heart. And under a microscope, this is what a healthy artery looks like. Beautiful pink. And blood is rushing through this artery very easily. Big, wide opening, big, wide lumen. This is a diseased coronary artery. This is fatty cholesterol plaque that invades the wall and narrows the opening, such that blood now is rushing through this on a much higher velocity. Coronary atherosclerosis is the name for this. Ather is a Greek word, and it means gruel, okay? Because it looks like chicken fat, because it actually looks like chicken fat. And all it takes when blood's rushing through here is this thin fibrous cap to break. And if that breaks and this breaks open, the body tries to clot off this damage and a blood clot occurs. And that's a heart attack. That's why you potentially could have a normal stress test in one day and die of a heart attack the next, because this can be a catastrophic sudden event. So here is a blood thrombus in that diseased artery. Here's the LAD coursing through. Here's that thrombus. And here is a heart. And this is scarred. This is a heart attack. This is scarred, dead heart muscle from a lack of blood flow, from a lack of oxygen. Now, obviously, that patient didn't do very well. But if you get to us, we can help you. We can intervene, which is why it's so important to call 911. It's interesting. You know what the worst person is if you think you're having a heart attack? The worst person to tell is your spouse. Because they're the ones who are going to say, oh, you're fine, you'll be fine. If you tell a stranger on the street, I think there's something wrong, I might be, I don't feel right, they're like, you should get that checked out, you should go to the hospital. So I want to tell you about a 68-year-old lady who was at the bridge table, and she developed actually very fullness in her chest, and she couldn't breathe very well. She didn't really know what was going on, but she knew something was wrong. And she acted, and she called 911, and she came to our emergency room, and we whisked her up into our catheterization laboratory. We anesthetized a tiny little area in her groin. We put a long, skinny tube up into the aorta, up into the heart, and we injected some dye into the 3 arteries that supply the heart with blood. This is how we treat heart attacks today. And here is a frame of blood flow down what should be her artery here, going down the front part of the heart. And we can tell when we're experienced that this looked like a little blood clot to us. So we put a different wire down there and we extracted this. A blood clot that was blocking the blood flow down the front part of their heart. She was having a heart attack. And look familiar? And then we put a different wire in, and this time the wire had a balloon on the front of it, on the tip of it. And in that area, we blew up the balloon, and on the top of the balloon was this stent. And we opened up that artery with a stent, and we restored blood flow, so she went from this to this. And she's back at the bridge table and the golf course, doing very, very well. Okay. And of all the things that Dr. Coller mentioned today about what Rockefeller has done as far as contributing to my world, he was very instrumental in an extremely important discovery of a drug called Riapro that we use in this situation to keep those stents open. So in general, men who present with heart disease will have more extensive disease on cardiac catheterization. In fact, 10 to 15% of women with bona fide heart attacks will not have any obvious obstruction when we take them to the cath lab. And believe me, this confused and frustrated us for a long time, and we just made up things. Why? But one of the things we know now is women are more likely to have vasospasm, and they're more likely to have disease in the microcirculation. We can't see that well in catheterization, but these tiny little branch vessels throughout the heart, that's where women are much more likely to have their disease. And we only know this through research that was supported by the Women's Health Initiative. Let's turn to stroke. Stroke is the number 3 cause of death for both men and women in this country. If a heart attack is when heart cells die because of a lack of oxygen, a stroke is when brain cells die because of a lack of oxygen. And there are 2 types of stroke. Hemorrhagic stroke, when a blood vessel ruptures and there's an ensuing bleed into the brain, which causes damage. And ischemic stroke, when there is a blood clot that forms in a blood vessel and disrupts blood flow. Or the other type of ischemic stroke is when that cholesterol plaque can break off from a blood vessel downstream and then cause obstruction of blood flow in a vessel upstream. 75% of all strokes in this country are ischemic strokes. Women are more likely to have hemorrhagic strokes than men, but again, ischemic strokes remain the most common one. And when you look at stroke, the story of stroke, it's a fairly similar picture to heart disease. Men develop strokes at a younger age. 3/4 of strokes happen in people over 65. But overall, women have more strokes than men in this country every year. 425,000 women had strokes last year, about 55,000 more than men. And women are not as aware of their risk. They are treated less aggressively, and they do worse than men. After a stroke, women are more debilitated at 12 months, and their functional outcomes and quality of life are consistently poor, even when controlling for age, pre-stroke status, and comorbidities. And also, the incidence of stroke is increasing in this country, and increasing fastest in our youngest adults. Okay, they're increasing in young men, and they're increasing in young women. And now we're seeing strokes in pregnant women and women in the postpartum period. And some of the reports say that this demographic, the stroke incidence, has increased by more than 50% in the last 10 years. But risk factors of obesity, diabetes, and hypertension have also increased significantly in this age group. So I want to take a moment and just say a word about aspirin, because I know it's confusing, particularly for women. And I've had women come to see me who have been taking aspirin, and I ask them why, and they're like, I think it's a good thing for me. Let me tell you what we do know. A man and a woman who have had a heart attack, aspirin will significantly reduce their risk of a second heart attack, a stroke, and death. Okay, aspirin, incredibly important medicine if you've had a heart attack. It makes you live longer. For primary prevention, an aspirin has been shown to prevent a first heart attack in high-risk men. such that the United States Preventive Service Task Force recommends the use of low-dose everyday aspirin in men over the age of 45 who are at high risk for heart disease. But no such benefit for primary prevention for women exists. Some experts say if a woman's very high risk, then maybe they should take a baby aspirin a day, but that's a little bit controversial. What we do know is aspirin a day, low dose, can help prevent a first stroke in women after the age of 65. But you always need to weigh the risks and benefits with bleeding because aspirin increases your bleeding, particularly gastrointestinal bleeding. So I want to tell you about the cardiovascular risk factors because one of the great things about being a cardiologist is there's so much we can do to prevent this disease. And even if you've had a heart attack, there's so much you can do to make you live healthy and long even after one. But we'd like to actually prevent the first one. So here are the risk factors. These are age, definitely increases with age, gender, okay? Men get heart disease and stroke at an earlier age, but once a woman gets diagnosed with either, she does worse and more likely to die from it. Family history. If you have a family history of heart disease and stroke, it increases yours. If your mother has it, it's actually a stronger risk factor. And diabetes. Diabetes is a much more powerful risk factor in women than men. I'm going to spend most of our time talking about the remainder. Hypertension, cholesterol, smoking, obesity, poor diet, physical activity, poor sleep, and stress, depression. Because these are the things we can do something about. And I think that personally these are things you can do something about, but I think that as a community and as a country and as a world, this is something we should be addressing and do something about. Because if you look at causes of death worldwide, in 2000 compared to 2011, this is ischemic heart disease or coronary artery disease. This is stroke. We are losing the battle here worldwide. So I think that paying attention to how we can reduce this, our risk of heart disease is a real important socioeconomic issue today. So hypertension, which is high blood pressure. A normal blood pressure is 140 over 85 or less. Hypertension is incredibly prevalent. It's more prevalent in young men, or it's more prevalent in men at a younger age, less than 45, but it's more prevalent in women after that. 70% of women who are greater than 65 years old have hypertension, and 65% of men. And this is a very powerful risk factor that if you can treat, you can get tremendous benefit because a reduction in your blood pressure of 2% translates into a 6% reduction in your risk of stroke, a 4% reduction in your risk of coronary heart disease, and a 3% reduction in your overall mortality risk. Very powerful. High cholesterol. I'm going to take a moment and explain your lipid profile to you because I think it's important. Your total cholesterol, we'd like you to be less than 200, but that's really not enough information. It's really hard to interpret what that means. You need to know the breakdown. And the HDL is the good cholesterol. It's the healthy cholesterol. And we really like your number, if you're a man, to be greater than 45, if you're a woman, to be greater than 55. This is the cholesterol that actually goes into the wall. It's a scavenger and takes out the plaque and brings it back to the liver to get rid of it. Really important. But we used to talk about the total cholesterol to HDL ratio. That's kind of old because no matter how good your HDL is, we really care what your LDL is. This is the lousy cholesterol. This is what goes into forming that plaque. And generally, we would love you to be less than 130. If you're high risk for heart disease, we want that number to be less than 100. And if you have heart disease, we want it to be less than 70. Triglycerides are another way the body carries fat in the bloodstream, very dependent on your waistline and your diet and your genetics. And generally, we want you less than 150. Smoking. Smoking is the leading cause of avoidable deaths in this country. A clear dose-response relationship exists between the number of cigarettes you currently smoke and your risk of heart disease. There is no safe level of smoking. Even smoking 1 to 4 cigarettes a day more than doubles your risk of heart disease. And the new low tar and nicotine cigarettes have never been shown to have a decreased risk with respect to heart disease. And even passive smoking, secondary smoke and third-degree smoke is bad for you. You know what third-degree smoke is? When you get into a taxi cab that you know somebody's been smoking in before, that's bad for you, increases your risk. And so the good news is that it's never too late to quit. And your risk of heart disease begins to fall within a matter of months after quitting and returns to the level of non-smokers within 3 to 5 years, regardless of the amount smoked, the age at cessation, or the duration of the habit. And there's only one sector, smoking has generally declined in this country, but there's only one section of our country that it hasn't, and it may still even be increasing, and that is young women. Obesity is an epidemic in our country. 2/3 of American adults are obese today, 2/3. And being obese triples your risk of heart disease. Even being mild to moderately overweight can double your risk of heart disease. And waistline fat is terrible for you. So it's not just about your weight, it's about your waistline, because the fat around your waist is metabolically active. It increases your blood pressure, and it makes your good cholesterol lower, your bad cholesterol higher, and it makes you prone to diabetes. So in general, we want women to be less than most desirable, women less than 29 inches, most desirable, men less than 35 inches. But anything that you can do that reduces your waistline makes you healthier. But liposuction doesn't count. Because it's the fat around the organs that is bad for you, not the fat underneath your skin. You are what you eat. This is really important. Your diet is not just about what you weigh or what your waistline is. You need nutrition to fuel you, to help you fight disease in the aging process. There was a good study that was published in the New England Journal of Medicine last year that compared the Mediterranean diet to a low-fat diet in 7,500 people living in Spain who are at high risk or had heart disease. And what we found after 5 years was what we find with most studies of low-fat diets. Nobody can really adhere to them. So the people on the low-fat diet didn't do a very good job at staying on their diet. But the people who adhered to a Mediterranean diet, which is largely a diet that consists of a lot of fruits and vegetables, beans, nuts, olive oil, fish, mostly white meat, wine, at the end of 5 years, had a 30% reduction in the risk of death, heart attack, and stroke. 5 years. And there was no difference in their weight. Okay? Too many people think it's just about what you weigh. You need good nutrition. And that being said, we could consider eating less. There are thousands of studies in animals and a few very good ones in humans that show that calorie restriction has been associated with longevity and living with less disease. Okay, I want to bring another story back to Rockefeller, the sugar story. I don't know if anybody was here during the Parents in Science night that we had a year ago with Dr. Robert Lustig, but he writes a lot about this. The sugar story is this, and I think it's extraordinarily compelling and a really important part of today's environment, because for so long we were told not to eat fat, so all our low-fat products, what did they put in them? Sugar. So leptin is a very, very interesting hormone. It's a protein that was discovered right here, okay? It's made by your fat cells. And when you eat sugar, it's released by your fat cells, and it's a messenger. It goes to the brain, says, you're not hungry anymore, stop eating, and start burning off your fat. Right? You give my son some chocolate, he goes a little wire, bounces off the walls. But if you give too much sugar, and you repeatedly eat sugar and sugar and sugar, the brain and the body are going to be sick of hearing from the leptin. They're not going to listen to it anymore. You become leptin resistant. So you never feel hungry. You never feel full. You always feel hungry. You never feel like burning energy. You keep storing fat, and you never want to get up off that couch. Very powerful. And 60% of the United States adults currently have no regular physical activity. And our children now are more sedentary, or less active, and more obese than ever before. We know that prolonged sitting predicts cardiovascular risk, and we know that physical activity improves your blood pressure, decreases your risk of diabetes, and increases your HDL cholesterol. By the way, it's the only thing, physical activity is the only thing that's really shown to decrease memory loss and improve cognition as we get older. It's not the New York Times crossword puzzle. It's taking a walk in the park. Okay, vigorous exercise as well as just walking are associated with substantial reductions and the incidence of heart disease. And just walking 20 to 30 minutes on most days has been associated with decreased premature death rates by 50% in both men and women. Sleep is a really important part of your health. And I was saying earlier that in medical school, I didn't have a course on sleep, on nutrition, or on exercise. Sleep is a really important part of your health, and sleep deprivation is not. 6 in 10 Americans claim they don't get enough sleep, and people who live the longest actually sleep between 6 and 7 hours a night. Lack of sleep more than doubles your risk of cardiovascular disease, and it can also lead to memory loss and cognitive dysfunction. And I'll bring it back to the leptin story. If you're sleep deprived, you have decreased leptin, okay? If you're sleep deprived, we still have the caveman physiology, okay? So if we're up all night running from animals, our metabolism slows down, we are really hungry, and we want to eat, all right? Leptin is the reason why you feel hungry, you want to store more fat, and you want to conserve energy so you don't feel like getting off the couch. And let me bring you into another protein messenger discovered here at Rockefeller, ghrelin. Really interesting enemy of ours. Okay, ghrelin is a peptide produced in the stomach that when you're sleep deprived is increased. And this not just makes you hungry, it makes you hungry for high caloric foods. This is why when you're really sleep deprived, you're craving that thing you don't usually ever eat. It slows your metabolism and reduces the body's ability to burn fat. So if you're trying to lose weight and you're sleep deprived, you really have no chance. It's hard to fight these. Stress. Stress is a powerful risk factor for stroke and heart disease, and most Americans today feel stress. And women are more likely to report that they have significant stress in their lives compared to men. And for those of us who feel stress, most believe that our stress is more now than it was 5 years ago. And 4 in 10 Americans today claim that they're exhausted, really burned out, and overextended with too many activities and commitments. Work is the -- 1 cause of stress for all adults, but family is #1 for women. And it reminds me of the study of male and female executives at the Volvo car company in Sweden that followed male and female executives throughout the course of the day and measured their blood pressure. And their blood pressures went up similarly throughout the course of the day. But after they went home, the men's went down and the women's continued to go up. And we also know from the Women's Health Initiative that women who report that their work is highly stressful are at a 40% increased risk of developing heart disease compared to their less stressed colleagues. So it's also that, not all stress is bad. We need stress in our lives. It entertains us, excites us, and it motivates us to perform. But too much stress, having that fight or flight reflex on chronically, causes wear and tear. Wear and tear on our body, wear and tear on our blood vessels and our heart, and accelerates the process of atherosclerosis. And anger, frustration, and mental stress can also trigger dangerous heart rhythms and lead to sudden death. Sudden death is much more common in men than women. And depression is another epidemic in our society. People who feel lonely, isolated, and depressed are many times more likely to get sick and die prematurely. Depressed patients after a heart attack are 5 times more likely to die within the next 6 months. But depression is highly treatable. It's important to reach out and get help. Similarly, stress is something that can be addressed, combated, and reduced in your life. You just got to believe it's important enough to take action. I think that too many of us, especially New Yorkers, feel that stress is some virtue. If you're not stressed, you're not doing enough. But stress is no virtue. It's a killer. And it's not just about how long we live. It's about how well we live. And it can be reduced. How do you reduce stress? Well, I think you have to come up with your own answer to that. But what works for most individuals are physical activity, particularly physical activity outside or with music, intimacy, sex, great way to reduce stress. But when it comes to your health, don't underestimate the people closest to you. Social isolation is detrimental to your health. People who regularly spend time with close friends have less disease and live longer. The presence of a spouse, a partner, or a pet are protective. But remember, not all relationships are good. Limit Limit your time with people who are detrimental to you, who pressure you to conform. You know who these people are. Spend less time with them. And I'm going to conclude with the fact that laughter may be the best medicine. Laughter has been shown to be linked to the healthy function of blood vessels. And laughter has been about 15 minutes of laughter is about equivalent as 30 minutes of aerobic activity with respect to your cardiovascular health. People who have a sense of humor, who laugh, who are optimistic, who can focus on the part of the glass that's half full, have less heart disease. Thank you.
Well, I want to thank you for this fantastic presentation. Maybe I'll kick off the first question. There's a lot of confusion about hormone replacement therapy in cardiovascular health. Maybe you can tell us what the current thinking is.
There's a lot of confusion because there's been a lot of confusion, and knowing the history might be a little helpful. For a long time, we were observing that women who took hormone replacement therapy had less heart disease and their cholesterol levels were lower. So we finally studied this, again, in a trial that was supported by the Women's Health Initiative called the HER trial, okay, hormone, estrogen, progesterone replacement therapy trial. And it was a national trial that looked at women who took hormone replacement therapy after the menopause against placebo. And it was stopped early in the spring of 2002 because of an increased risk of invasive breast cancer in the treatment arm. But not only was there an increased risk of invasive breast cancer, there was increased risk of heart attack, blood clots in the lung and in the legs. So it really wiped out hormone replacement. I remember I was on maternity leave at the time and I got a lot of phone calls at home about that one. But it really kind of made people stop and wonder and stop hormone replacement therapy. Yet, women have terrible symptoms, perimenopausal symptoms. So where are we right now? Well, I don't think there's ever going to be a huge, large trial like that, but I think that women who are taking estrogen patch or vaginal cream to help with localized symptoms of vaginal atrophy and pain during sex, and people who take the patch or sprays or otherwise to help a little bit with hot flashes, that seems to be much safer. I still think we are not giving hormone replacement therapy to prevent heart disease. That's clear. However, there was a study that was just published or just finished out of Denmark that followed women 10 years after the menopause. And actually, these women who were young women started right after the menopause on hormone replacement therapy, not the old Prempro that we used, but smaller doses, actually had less heart disease and less death. So I think that it's still controversial. It's up in the air. The recommendations by our medical society are that we're not using it to prevent heart disease. There are other things that you use to prevent bone loss. There's not a lot out there that helps perimenopausal symptoms. So I have many women who elect to take hormone replacement therapy. We get them on the lowest dose possible that makes them feel better. And we see, you know, and I usually, because maybe we know that hormones increase your blood clotting. So I have a talk with them about starting low-dose aspirin when we do that. Don't know, just think that's the right thing. And I think there will be other studies, probably not done in this country, that will help us with that going forward. Not clear-cut answer, but.
Great. And we're now going to open the proceedings to questions from the audience.
I was wondering what happened in 1984 for your chart to show that the curve for women changed and started going up.
Yeah, I don't think any one thing happened. I think that we actually have been really good at treating heart disease. We're really good at treating you once you have the disease, okay? But we're really, really bad at preventing it, okay? And I just think we've been much more aggressive about treating men and treating men earlier, treating men more aggressively, and even talking to them about, I mean, men know they're at risk for heart disease, okay? Usually it's their women's trying to get them to, you know, wives trying to get them to behave better. But I think that we're behind the curve here with respect to women. Not one thing happened in 1984. That's just when the number of deaths changed.
I'm wondering, what does a healthy death look like if we step back? Because we're all going to die, so what if I can use that oxymoron?
Yeah, that's a really good question. And I think that death shouldn't be, oftentimes, you know, it's not a defeat. We all die. Some do it better than others. And, I think at some point later in life that, if you have to pick a death, sudden death from heart disease isn't a bad one. But, as far as this prevention model, you can look at hunting and gathering societies in third world, in parts of this world, where there's really not been much cardiovascular disease ever, okay? And within one generation of becoming urbanized, where they leave the fields, go to the city, get desk jobs, start smoking, get stressed, eat fast foods, heart disease becomes the #1 cause of death. So I get that at some point it's okay to die from this, but not what's happening in our young adults.
Over here. Thank you.
I'm interested in the symptoms of having a heart attack. Shortness of breath, what do you look for? How do you know over 60, say, is shortness of breath normal, not normal?
I think that's a good question. First of all, what I showed you was a heart attack, okay? So a heart attack is a sudden event, okay? You're one way one moment, you're different the next. So heart attack symptoms are much more atypical in women. Again, most women have chest pain, okay? But 40% have other symptoms. The heart can't feel pain, so you might feel pain, so the brain has to make up some place for it to come from. So it's sometimes the jaw, the back, the arms. Sometimes you just can't breathe, you can't take a deep breath, you become sweaty, you feel indigestion. But most women know something's wrong. You might not know what's happening, but you know something's wrong. And we'd much rather be treating indigestion in the emergency room than missing heart attacks. Now, to answer another question, a lot of times, instead of 100% or 99% occlusion, you can have a plaque rupture and you go from 0% to a 70% blockage. And if that happens, the only thing you might notice is that, boy, every time I walk up these stairs, I get short of breath now. Or boy, every time I rush to go to the bus or I rush to go something, I get a little chest tightness. If you start experiencing exertional symptoms that are new, that weren't there, that go away when you rest, call your doctor, okay? Those are very concerning symptoms.
Holly, everybody I know is taking statins. So we talked about aspirin. What about statins? Are there any downsides to taking those?
I kind of thought someone was going to ask that question, especially Dr. Breslow here. I'm going to give you a little. This is a tough one, right? First of all, if you have had a heart attack or stroke, please listen to this. If you have had a heart attack or stroke who have been diagnosed with heart disease, statins make you live longer. We care about a lot of clinical endpoints. Okay, what's your blood pressure, what's your cholesterol? This is the most important clinical endpoint. They make you live longer, okay? The question really comes with primary prevention in people that don't have the disease. Now, they make you live longer with about a 36% reduction in your future risk of stroke and 30% reduction in your second risk of heart attack. So very, very, very important part of our treatment for people with heart disease. The question is, and we've also shown that through studies that if you look at plaque in an artery, I showed you the plaque in the artery, we can measure through an ultrasound a volume of plaque in anyone's artery. We've shown that statins actually can reduce cardiovascular disease, reduce the plaque amount over time. We've shown that, okay? And I think the studies in men for primary prevention have been stronger than women, okay? If you're very at high risk, at some point, if you can't get it down through diet, physical activity, waistline loss, and by the way, drugs never trump lifestyle. Never, okay? It's not okay to just eating your cheeseburger on a statin. Lifestyle matters, okay? But statins can reduce your LDLs and get them into a better range and have been shown to reduce atherosclerotic plaque. But there are some, I think the real controversy comes about now that there are studies, there is a Jupiter study that says, in women, relatively young women who have average cholesterol levels, but something called a CRP, which is a measure of inflammation, was elevated, and we put these people, thousands of people on statins, and how many lives you're really saving? Tiny. And what are the downside? Okay, so I kind of put this up for you. So when we did a lot of the placebo versus statin-controlled trials, this is like a pooling of them. We talk about liver enzyme abnormalities. 1.4% in statins, 1.1 in controls. 15 muscle complaints, really common, 15.4 in statin patients, 16.7 taking a dummy pill. Now, that doesn't mean some of my patients don't develop cramping on statins. They do. We try different ones, and we try. Really serious inflammation of muscle, 0.9% statins, 0.4% in placebo. Muscle inflammation. This is one that's gotten a lot of attention, the diabetes risk. 5 per 1,000 statin-treated persons over 5 years get an increased risk of diabetes. Okay, something that Dr. Breslow talked about 2 years ago before it ever got into the press. So this is real, and it would probably make you say, well, okay, I have a 28-year-old woman with a terrible, LDL, but she has no family history. Do I'm going to commit her for a whole life of statins? You take pause when you're talking about the evidence of primary prevention in women putting on statins for their whole lives. But if your cholesterol levels are high and you have other risk factors, it should be discussed. And the memory loss one, the government kind of said, well, they may be causing memory loss, and I think, that's out there. They've actually studied statins to help reduce dementia, because the second most common type of dementia that exists is vascular dementia, which is the tiny little blood vessels in your brains that get all clogged up. So there's actually some people who actually believe that statins can reduce that. That hasn't been shown either. Okay.
Yes.
I've noticed that there's a significant difference in blood pressure levels between men and women, and yet the point that people are treated between men and women seems to be the same. And is there any research that separates the two and that would maybe indicate there should be a lower level that women are being treated at?
So whether that maybe we should start treating women less than 140 over 85 or less? Yes. Not really gender-based. I'll tell you what one surprising study was, though. We thought that diabetics are very high risk, right, for vascular disease. So we actually took a bunch of, we took diabetic patients, people who had severe diabetes, and we took one group and we just treated them normally, tried to get a blood pressure of 140 over 85 or less. Tried to get the other group to more like 120 over 80 or less, which we never did. We got them to about 130 over 80. No difference really between those two groups, which surprised all of us, okay? So we try to treat down below 140 over 85 or less. We don't push down below that. And no, I don't know of any data that shows that we should be starting earlier for women. But if your blood pressure is lower, it's better, okay? I don't know if any of you, if you're in good shape and you've not, in your own lives, you could probably tell, boy, there's sometimes my blood pressure is better when I'm in better shape and eating better and sleeping better than when I'm stressed and not eating and eating bad. And that matters. I mean, that's a two indications of your health. So the question was, does it matter what type of day, what type day do you take your blood pressure? Aspirin. Oh, aspirin. No, it does not. But that blood pressure, it doesn't matter what type of day. Your first waking blood pressure is going to be your highest blood pressure of the day. So I usually have people like, I woke up and my blood pressure is 150 over 85. I'm like, okay, take your medicine. If we treat down really below that, by the time you're 4 o'clock, you're going to be too low. We really, the best way to treat blood pressures is a 24-hour blood pressure monitor, which, we don't do that often, but it's coming because your iPhones are probably going to be able to do it soon.
First of all, thank you very much. It was very informative.
Thank you.
Holly. But I wanted you to talk about TIAs a little bit. Could you just tell
Sure.
us?
A TIA is short for transient ischemic attack. And a transient ischemic attack is otherwise being talked about a mini stroke, okay? So a mini stroke is when you have symptoms of a stroke, but they last for less than an hour. And sometimes they only last for 4 or 5 minutes. And we don't find them, okay? You can't really see them on an MRI or a CAT scan or a blood test. So the only thing we have to go on is your history and what happened during those few minutes when you couldn't get the words out that you wanted to, okay? And that is a clinical diagnosis. You recover completely from TIAs. There's no footput, there's no residual. But if you've had one, you better believe that your risk of a future stroke is significantly increased because you just got lucky. It was a little thrombus or it was a little plaque, and then your body got rid of it. But it's the same mechanism. It's the same disease mechanism.
Is it hereditary?
Well, I think that, this whole process of atherosclerosis and heart disease and stroke does tend to run in families. A TIA itself is no. And again, just because you have a terrible family history, okay, doesn't mean you can't change it with lifestyle and prevention and aggressive risk reduction. And that is somebody, if there's a big family history of stroke, certainly that is a woman who, as she approaches 65, might, should have good blood pressure, should be eating well, physically active, but maybe you really think about an aspirin a day in that person.
Yes, back.
I've heard that an aspirin a day puts you at risk for macular problems. Is that true or not true?
I didn't see where that came from. Oh, macular problems.
Yeah.
It doesn't increase your risk of macular degeneration. No, I think that if you have wet macular degeneration and you've been bleeding, then or if you have a family history toward that, you should be, again, risk the risks and benefits of aspirin use, but it doesn't cause macular degeneration. It may exacerbate wet macular degeneration. But quite frankly, I've dealt with a lot of we used to treat heart attacks with blood thinners, like clot busters, big powerful ones. And they've let us use that even, with people with terrible macular degeneration, wet degeneration. So I think you should speak to your ophthalmologist, but not generally, no.
You mentioned in passing the Mediterranean diet, and which you also mentioned in passing wine as part of the Mediterranean diet. So what's the latest on drinking? And it's a fact on heart. I know it's early, but...
No. I think you'll like this answer. Actually, men and women who consume moderate amounts of alcohol, and how is that defined? 2 drinks, 2.5 drinks a night, maybe 2 or 3 for men, 1 to 2 for women, have been shown to have less heart disease on a population basis, okay? You can't have your 14 drinks on Saturday night, not binge drinking, but enjoying a glass or 2 of alcohol a night, and it's alcohol. I know the red wine people have really capitalized on this, but there are studies that show not just red wine, but white wine, but any types of alcohol, actually in moderate amounts has been shown to reduce your risk of cardiovascular disease. Now, alcohol is something that also increases your blood pressure and causes insomnia and causes rhythm abnormalities and causes stomach distress. So I don't tell my patients who don't drink to start drinking. It also really one of the things that increases your good cholesterol. Physical activity and alcohol are about it. We have drugs that increase your HDL, but so far they've just killed people. So we stick to lifestyle. But I have to at least say that the breast cancer literature, that literature is coming out and saying, even probably 1 alcoholic beverage a week is not good if you ever, for breast cancer. So again, you have to know, what most people die of. You have to know your genetics. You have to get screened. That's the literature there.
Is there a correlation between migraines and strokes or heart disease?
Love that question. Yes. Migraines, yes, but not as much as, but if you have migraines with aura. If you have migraines with aura, you actually have a significant increased risk of stroke, okay? It's tiny, but it's significant. And what is migraine? I've actually had some patients, and some people know who they are here, young women who've actually had strokes from vascular migraines, right? Okay, what is a migraine? A migraine is when your blood vessels in the brain vasoconstrict, and that's when you get, if you have aura, you see lights and you see weird things because there's not enough blood really going to that part of your brain, and then they vasodilate, okay? And that's all the blood rushes to your head, and you feel terrible with a headache. So during that vasoconstriction part, I've actually had a couple of patients who have stroked from that vasoconstricted part. And we actually see that on their brain. And we actually, because they're 38 and 100 pounds with a blood pressure of 90 and have no cholesterol, think it's probably not atherosclerosis disease, but their migraines causing this. So yes, and that is, if you have a migraine with aura, if you are somebody during pregnancy who had high blood pressure, of gestational diabetes, these are signs that we should be even more aggressive in your risk reduction.
You mentioned that sleep is very important, and yet many people as they get older have great trouble sleeping. What's the role of sleeping pills, the pluses or minuses in preventing heart disease?
Good question. I ask everybody what they're, that comes to me, I'm like, well, how's your sleep? And so many people are like, oh, my sleep's terrible. I'm like, well, why? Well, I go to bed and I wake up at 3 in the morning. I'm like, everybody wakes up at 3 in the morning. I think some people don't realize that you're not supposed to sleep like you did when you were 10, okay? See my son fall asleep, he sleeps in the same position as he wakes up in the morning. It's like unbelievable. When, the sleep cycle is 90 minutes long. That means you sleep. It's very, interesting architecture. You fall asleep, you start getting down to sleep, you get deeper sleep, you kind of come up. You might roll over in bed, then you fall asleep, and that's why you wake up at the same, because you probably get through 2 or 3 sleep cycles, then you wake up. And it's normal to wake up. The question is, how can you get back to sleep? And it's okay to get up and go to the bathroom, and then you try to get back to sleep. And it's not really good to take a drug. People take drugs for 2 reasons: to get to sleep and to stay asleep. Most people can fall asleep, and then they wake up and can't get back to sleep. And other people, the people that really can't fall asleep, that's even more stressful. And that's probably even more of a role. If you can't fall asleep, and you've tried a good pre-bed routine, really important, sleep hygiene, bed should be for sleep and sex. It's not your office, it's not a movie theater, it's not the place to read, it should be for sleep. So your body has to know when it's in bed, okay? It should sleep, and you should have a pre-bed routine. You play tennis, you play golf, your body needs to know it's time to go to bed now. You wash your face, you do your thing. It's always good to try non-drugs, but if you really can't fall asleep, it's better to get up and do something else until you're tired and go back. But I think sleeping pills are probably best for people who can't fall asleep, because that's highly stressful, and you got to restore a sleep cycle. I think sleep is really, really tough when you're going through a very, very stressful time and you got to get to some sleep. I think drugs are very helpful there. I know that a lot of you take sleeping pills every single night, and we just don't have literature about that. And once you start, it's hard to stop. There are newer drugs now, maybe you've heard about them, that if you do wake up at 3 in the morning, instead of having a pill that stays in your system all night, you take it at 3 in the morning and hopefully just take a smaller dose to get you another couple hours or 3 or 4 hours of sleep. There are techniques to try to get you back to sleep at 3. Instead of thinking about all the things you have to do and what somebody said that really made you angry, you can try to think about what you were just thinking about before you woke up. And this technique works. Think about what you're thinking about before you woke up. And it won't be a dream. It'll be some thought, where you let your brain kind of go and wander off. And you can find yourself going back and forth. But you can get better at going into try to induce sleep. So I always try to work with people to do things before taking a drug every night, but clearly a lot of New Yorkers on a drug every night, and we just don't have any long-term, most of the drugs, Ambien, they've only been studied for a few months. Lunesta has been studied long-term, 6 months. We don't have any long-term data. But sleep is important, okay? And sometimes that trumps non-sleeping.
So we're going to have one last question in the back.
Thank you for a fabulous talk. I also wanted to know, if you feel you're having a heart attack and you call 911, should you take an aspirin, and what should you expect?
Yes, that's a great thing to do. If you think you're having a heart attack, chew an aspirin. That it's one of the most powerful drugs we have to treat heart attacks today. And and call 911. And if you really think there's something wrong with you and you really think you could be having a heart attack, okay, maybe you have back pain, maybe you have shortness of breath, when you go in the emergency room, you tell them you have chest pain. Because we are set up, we're putting chest pain clinics everywhere in this country, including at New York Presbyterian Hospital I work. We are chest pain certified. But 40% of women that don't have heart, if you say you're having chest pain, you're whisked back to have an EKG right away. So if you really think, don't say, I really don't think I feel right, maybe I'm sorry for being here, you have chest pain. Okay?
On that note, I want to thank Holly again for a great talk.
Thank you.
Congratulations.